I will show a vitrectomy for a vitreoretinal dystrophy. This is a 13-year-old boy, visually impaired, severe myopia with astigmatism, -40, -15. Here you see the fundus picture with the optos photograph with pathologies in the vitreous and in the retina. He is highly myopic with -14, OCT of the right eye. You see traction on the macula with a lamellar hole and a defect of the retina. I'm starting the surgery. I'm using 27 gauge. This is a huge advantage for myopic eyes and for young eyes, of course. Here you see the fundus of the eye, the vitreous cutter. I'm using a DORC system. So this is a 27 gauge TDC cutter, 16,000 cuts per minute. Here you see the vitreal pathology. I'm first doing a core vitrectomy, and before I try to address the pathology which is so apparent, I'm using the 27 gauge cutter, of course. It is very good instrument for this pathology, and you can go very close to the retina with this cutter compared to 23 and also compared to 25 gauge. So you see that I'm reducing now the cutting frequency to 1000 cuts per minute and carefully removing this fibrotic tissue. I continue with the staining of the vitreous with membrane dual from a DORC, which stains vitreous, membranes and ILM. Now I'm using a 27 gauge PIC instrument from DORC, which I like very much, which can even elevate very small membranes which sit very close to the retina. I use this even in 25 gauge or 23 gauge surgery because the small size of this PIC is a huge advantage. So after elevation of this membrane, I cut it with a vitrector. Now I'm using a forceps. This is a ultra peel forceps 27 gauge from DORC. And again I use the cutter 27 gauge to remove these fibrotic vitreal membranes. With the forceps I'm removing this thickened posterior hyaloid and then removing it with the vitreous cutter. Again, I'm using a ultra peel 27 gauge forceps from DORC, which is my favorite forceps. So this is a 14-year-old boy with a vitreoretinal dystrophy, high myopia, and also a ischemic retina. That's why we also did a laser coagulation, which will be shown later on during the surgery. Now I'm trying to assess the macular pathology. He has a lamellar hole on this eye. Visual acuity is low. So now I'm trying to trim this tissue and then removing more of this vitreal fibrotic material. You see it sits very tight here to the retina. So I always try to work defensive and remove all tractions as much as possible. But I do not insist in order to prevent retinal breaks. So now I'm cutting this bridge with the cutter. And you see that's very easy. Now you see a broad adhesion of this vitreal membrane to the retina. So I'm indecisive whether I can remove it or not. Removing this part again with the cutter. And again, the advantage of this 27 gauge cutter is that you can place it very close to the retina. This is not possible with a 25 gauge cutter, and of course not with a 23 gauge cutter. You see the pathology in the periphery. Doing an angiography, the retina in the periphery was ischemic. There was no growth of vessels, so we do a scatter laser coagulation of this area. Here you see is the posterior hyaloid, which is partially detached here. So now I'm doing a rhexis in the posterior hyaloid between the equator and the ora serrata, just to relieve the traction which the posterior hyaloid does oppose to the retina. So I'm just opening it to reduce some possible traction. And then I complete the scatter endolaser. I insert now in addition a twin light from Dork to help me with the laser coagulation. So now I'm impressing the retina with a depressor, and I'm doing more. I'm increasing the rhexis of the posterior hyaloid on the other side of the eye, on the nasal side. So I'm doing a rhexis in the posterior hyaloid to relieve traction of the posterior hyaloid. And again, I add scatter laser. If you have twin light or chandelier light, you can work up to the ora serrata. So now I'm going back to the macular pathology. You see there's a thick membrane, residual membrane on the macula. I'm trying to assess if I can remove this residual pathology. Here's the OCT. It's not a full thickness hole, it's a lamellar hole. Visual acuity is 0.1, 0.2, so it's very low. So I'm trying to remove more of this tissue using a 27 gauge ultra peel forceps. And now I'm cutting down this membrane again with a cutter, 500 cuts per minute, so a very small cut, and 200 millimeter mercury aspiration. I remove the trocar cannulas, and now this is 1 month post-operative follow-up. You see the scatter laser, some membrane is left. Now you see a closer up. The macular hole is not longer visible. So it's a huge improvement for the patient. Thank you very much.